Good evening, and thank you for joining us. My name is Donna Winowski, and I'm the president of the Pericarditis Alliance. I'm also a pericarditis patient. On behalf of the Pericarditis Alliance, we are very pleased to bring this special program to you this evening. The Pericarditis Alliance is a nonprofit organization dedicated to the proper diagnosis and treatment of pericardial disease. Tonight, you'll learn about pericarditis from Dr. Alan Lewis of the Mayo Clinic, and you'll have your pericarditis questions answered by Dr. Alan Klein of the Cleveland Clinic, Dr. Alan Lewis of the Mayo Clinic, Dr. Chadi Al-Rayes of Detroit Medical Center, and Dr. Martin Lewinter of University of Vermont Medical Center. My fellow board member, Rachel Freeberg, will join me in moderating questions. Thank you to everyone for submitting questions in advance this evening. We have done our best to provide answers, or will be doing our best to provide answers to everyone's questions. At the end of our program, we'll show the names of our presenters and their locations again, as well as our website and our contact information. But just so you have it, our web address is www.pericarditisalliance.org. On our website, you'll find biographies on all of the doctors that are presenting this evening, as well as links to helpful articles and information about pericarditis. On our website, we also have links to two of the centers of excellence for pericarditis, the Mayo Clinic and the Cleveland Clinic. We will be recording this evening's presentation and we'll post it to our website, hopefully by tomorrow. Thank you again for joining us. With that, I am so pleased to introduce Dr. Lewis to share with us what is pericarditis. Dr. Lewis.
Thank you very much, Donna. So I'm going to start the evening by sharing a little bit about what is pericarditis. And so let's start with what is the pericardium. So the pericardium is a sac, kind of like a skin that surrounds the heart. It can become inflamed, which is what causes pain, or it can become thickened and scarred, which can cause swelling on the legs and other such symptoms. You would have heard a variety of different terms during your journey through pericarditis, and I'm going to try and simplify them a little bit for you. Acute pericarditis is essentially a single episode of inflammation that resolves and doesn't come back. Then you'll hear a variety of different terms: incessant pericarditis, recurrent pericarditis, and chronic pericarditis, all of which together are sometimes called complicated pericarditis. These three terms demonstrate or are used to define pericarditis that lasts beyond a single episode with ongoing inflammation. And over time, in a small subset of people, or as a different disease entity, this can cause the pericardium to become thickened and scarred, restricting the heart's pumping function, called constrictive pericarditis. The treatment of pericarditis, or the assessment of pericarditis, really requires a careful relook at you as the patient. We need to start with a detailed history and figure out what's going on, how have you been treated before, and what are the triggers for your flares. We need to examine you carefully, not just looking for features of pericarditis, but also to look for other causes that may masquerade as pericarditis this time round. We use blood tests called inflammatory markers, ESR and CRP to name a few, to look for, is there inflammation anywhere in the body? This is not specific to the pericardium, but tells you about inflammation overall. We can use an echocardiogram to look for features of pericarditis, and we can use a cardiac MRI also to look for features of pericarditis. And these two tests provide different information. So the echo and cardiac MRI provide completely different and complementary information, such that one test is not necessarily better than the other. In terms of our treatment of inflammatory pericarditis, we use a stepwise approach in treatment. We usually start with aspirin or a non-steroidal anti-inflammatory, such as ibuprofen or indomethacin, and use this in combination with colchicine and restrict people's exercise, because that is something that we know can also cause a flare of pericarditis if they're exercising during an acute flare. We then, if people don't respond or have bad reactions to treatment or side effects from treatment, we move down the treatment ladder. And our next stage is steroids with colchicine. Then we can try steroids, colchicine, aspirin, and or a non-steroidal anti-inflammatory. We can move on to immunosuppression using IL-1 inhibitors, azathioprine, or IV immunoglobulin. And then as a last resort to treatment, we can proceed to performing a surgical pericardectomy to remove the pericardium in its entirety. And in those patients that don't have inflammatory pericarditis, who have constrictive pericarditis, then the treatment would be surgical pericardectomy. Thank you all very much for your attention, and we'll move on to the questions.
Great. Okay, thank you. Thank you. That's a wonderful overview, Dr. Lewis. Thank you so much for giving us that perfect foundation for us to now build on with questions. So our first question goes to Dr. Klein. Dr. Klein, I have read about proper diagnosis. How is pericarditis properly diagnosed and how often is it missed? Or how is it often missed? Are there specific tests I should ask for? But if all of my testing and markers are normal, can I still have pericarditis?
Thanks, Donna and the Pericarditis Alliance group. Rachel, thanks for organizing this state-of-the-art webinar. As we heard from Dr. Lewis from the Mayo Clinic, he went over some of these findings. So the proper diagnosis is often linked to the ESC guidelines. So they have some criteria. So we want to see if they have the classic features: pleuritic chesting, pain in the chest when they take a breath. Often you get referred to the left shoulder. Do they have a rubbing sound when you listen with the stethoscope? Is there increasing pericardial effusion or fluid around the heart? And does the EKG almost look like a heart attack? So those would be the clinical criteria, and you need 2 of 4 of those 2 of 4 criteria. Then you need objective findings, things that Dr. Lewis mentioned. CRP or SED rate should be elevated, and now we have a imaging biomarker, MRI or CT or even PET scan, but specifically MRI will light up if there's active pericarditis. So those are the criteria, and I should mention, it sounds very straightforward, but in my practice at Cleveland Clinic, 20% of people that come here claim they have pericarditis and don't have pericarditis. So you have to be a very astute clinician like all the panelists and take a very good history. Can you have pericarditis when none of the tests positive? It's possible. You don't have the inflammatory phenotype, but if everything is really negative, then you question another diagnosis. So that's in a nutshell.
Thank you. Our next question is for Dr. Lewinter. I'm told that my pericarditis is idiopathic, which I think means that I got it from a virus. Should I be worried that this virus will come back? When is pericarditis acute and when is it chronic or recurrent? Oh, we can't hear you.
I want to apologize. After 2+ years of Zooming multiple times a week, apparently I can't get a screen behind me, just the logo. So there you go. There are many causes or etiologies of pericarditis. The list is very, very long. And when we use the term idiopathic, what we're really saying is based on a standardized evaluation, which includes things like echocardiograms, a careful history, et cetera, we arrive at the conclusion that there is no clear disease that you have causing your pericarditis. For example, something like lupus can cause pericarditis. So when we go through a standard evaluation, we don't find any indication of some other disease that can cause pericarditis. So we use the term idiopathic, which simply means we don't know what caused it. And there has been the conventional wisdom is that most cases of idiopathic pericarditis, at least a first episode, are caused by viral infections. The evidence for that is not that great, actually. This is not easy to really study, and a lot of patients certainly do have symptoms which are suggestive of a viral infection before they come down with pericarditis, but the actual evidence is, in my view at least, is not that strong that's the case. I believe it is, but again, in terms of evidence, that's another thing altogether. So when you say, will the virus come back, I think what you really mean is, am I going to get this again? And our current thinking is that whether or not the first episode is a virus, and let's say that it is, if you have recurrences, we no longer think that that's the virus coming back. We think that this is a disordered process going on in your immune system, which is not necessarily related. Well, it is related to initial virus, but we don't think it's a viral infection coming back. So I think that was it, right, Donna?
I think so. I think so. And we did touch on what's acute and what is
right,
chronic or
right.
recurrent pericarditis a little bit in Dr. Lewis, but if you touch on that.
Well, let me touch on that again. Acute simply means a single episode, typically a first episode of pericarditis, and most of those go away with conventional treatments that we use, which I'm sure we'll touch on. Recurrent pericarditis, by definition, we say is present if you have recurrent symptoms following a 4 to 6 week period in which you have no symptoms. Here you might get treated, again, in some standard fashion. Your pericarditis responds, you have no more symptoms, but 6 or 8 or several months or later, you get a recurrence. That's recurrent pericarditis. Incessant pericarditis is pericarditis that where the duration is between 4 and 6 weeks and 3 months. And finally, chronic pericarditis is at least 3 months after an initial episode. So these are a little arbitrary, and many cases don't fall neatly into one or the other category, but that's in general the way we think about these terms.
Great, thank you. Dr. El Reyes, I have a few questions for you. These are regarding flares. Should I go to the emergency room every time I have a flare? What is happening to my body during a flare? I should probably ask if you'll please define a flare. Those of us with pericarditis know what it means, sort of. If left untreated, what are the risks of a flare? And why does it feel better in a flare when we lean forward?
Thank you again, Donna and the Alliance, for the hard work on putting this webinar. And again, thanks for everybody who joined us tonight. So flare is meaning that there is an acute phase of inflammation that is purely localized to the pericardium, which is the susceptible area of the body at that time. Similar to lupus, rheumatoid arthritis, or any other flare of inflammation, pericarditis is inflammation purely, as Dr. Lewis and Dr. Klein illustrated earlier, is pure inflammation of the pericardium. Flare also most likely means that somebody who had a pericarditis before, and now he has or she has a new episode of recurrence. As Dr. Lewinter mentioned earlier, is this something a recurrent issue or recurrent episode, or this is it can be worse, can be milder. Now, the definition of it is the mechanism of it is anti-inflammation, interleukins, as well as other biomarkers in our body kind of go up. The most common, and I think most of us are familiar with the ESR, as well as the CRP or C-reactive protein that are measured in the blood serum, suggesting that there is a trend toward a peak during that episode. This is sometimes go up from any other reasons. If you have a flu-like symptoms, if you have a joint inflammation or lupus, can go up as well. But it's definitely, if somebody has a trend of pericarditis or a flare, so definitely will go up more than usual compared to the baseline numbers. in terms of the second part of the question is, do I need to worry about these flares and can I leave them untreated? Definitely leaving them untreated will be discomfort, will cause the pain to persist. But beside that, as illustrated earlier, that can put the patient for a recurrent or even chronic pericarditis. These nice layers that Dr. Lewis showed us earlier on the image, thin 1 or 2 millimeter layer between the two layers of pericardium can get thickened, and also this can be more adhesed to each other, adheres to each other, and also can cause what's called constriction. So definitely every flare has to be treated, and every flare has to be really treated rather acutely with the medication. I think we're going to go over it, but briefly: NSAID, aspirin, and colchicine. Now, the last part of the question that asks about should I go to emergency room every time? Well, if you are familiar with the symptoms, definitely we don't want to mix between the symptoms of heart attack as well as pericarditis. It's the same organ, it's the same location. If you are familiar with your symptoms and this is a recurrence of the same symptoms, then it's a pericardial inflammation. But apparently, if you are a person who is a little bit with the risk factors, smoker, diabetic, hypertension, and family history of heart disease, then definitely you don't want to mix up and you should report to emergency room or emergency department.
Thank you. Dr. Lewis, the next questions are for you. The question begins with, can I have a pericardial effusion without having pericarditis? And will you please describe the difference? What's the difference between a pericardial effusion and pericarditis? Can a mildly thickened pericardium ever return to normal, or is that thickening permanent? What is the cause of the chest discomfort or pain we feel, even when sometimes other diagnostics don't indicate inflammation?
Perfect. Great question. So first of all, the pericardium sits on top of the heart. The heart is moving 60 to 100 times a minute of every day of your life. And so you can imagine that there would be a lot of friction between those two layers. And so there is a little bit of fluid in that space around the heart, in between the layers of the pericardium. And it's basically like a lubricating fluid. It's there to provide lubrication between the layers of the pericardium and the heart that's constantly moving. And so some amount of pericardial fluid, also called a pericardial effusion, is normal. The question really winds up being, how much fluid is there? And there is variation between people in terms of how much pericardial fluid they have. We use the pericardial effusion as a sign that there is some inflammation causing more lubricating fluid to be in that place. But when there is a tiny amount, it could be your normal fluid, or it could be related to inflammation. And it's difficult to tell unless you've had a previous echocardiogram or CT or MRI for comparison. It's easy when it increases in size. It's easy when it's large or moderate in size to say this is likely the consequence of inflammation, especially in a person that has chest pain. But when there's a tiny amount, it doesn't definitely say that I have pericarditis unless you have the other features to go along with it. Your second question was related to pericardial thickness. As happens when you scratch your arm or get a deep cut, inflammation results in redness and a lump. Same thing happens with the pericardium. If there's inflammation of the pericardium gets thicker. As you treat the inflammation, the pericardial thickness will hopefully go back to normal. It is possible that some scarring happens to the pericardium. It's generally thought of as being unusual in inflammation to result in a lot of scarring, but it is possible to get scarring, and that can leave you with thickening that's persistent in the long term. Your third question was regarding chest discomfort, and what else could it be in someone where the tests indicate that you don't have pericarditis. And as Dr. Klein said earlier, really, it's important that we look for all the other causes of chest pain. You have your lungs in your chest, you have a food pipe in your chest, and you have muscles around the outside of the chest. And so we need to think about all of those things as potential causes of chest pain. Some people, depending on how they describe their pain, may have chest pain related to reflux. Some people, depending on how they describe their pain, may have lung pain related to a clot in the lung, infection, or inflammation. Some people may have muscular chest pain coming from the chest wall, and this is where it's really important that you have someone that looks very carefully, doesn't just assume the diagnosis of pericarditis, takes a step back and looks at you with a completely fresh look without any assumptions to figure out what's going on.
Thank you.
Hi, these next questions are related to treatment. And Dr. Alres, are you ready for the next question? I have, what is the treatment protocol for pericarditis? What should I expect when I go to the emergency room for a pericarditis flare? Maybe what tests, treatments, and imaging might I anticipate?
Let's start by what test the patient will be receiving when they go to emergency room. This can be done also when the patient come to clinic. Today, I had a patient coming to clinic with these symptoms, having chest pain. So again, tests were going to be a serology or blood test, including, as I mentioned earlier, ESR and CRP and other basic blood tests like blood count and white count, and kidney function, some basic blood work. Imaging, definitely the first test will do what's called electrocardiogram, ECG or EKG. This is just as a heart monitor to evaluate the changes in the electricity of the heart. That test to make sure you don't have a heart attack. It's just purely pericarditis, or this is other etiology or abnormality in your EKG. X-ray usually standard for any patient, especially for the first time. But then if you want to take it one step closer, if your patient get admitted, then expert like the panel we have, they usually order echocardiogram to evaluate if there is any fluid collection around the heart, if there is any signs of side of the heart not working as strong as the others. So this is kind of when the patient get to the hospital. One more step closer, further, which is Dr. Klein and others have done a lot of research on, is to do what's called the cardiac MRI. This is kind of to delineate more the severity and the intensity of the inflammation. This is by injecting a special dye that hang up to the inflammatory in the inflamed tissues in the heart, and usually it lights up, suggesting acute inflammation. And usually some researchers follow this periodically to see if this inflammation is getting better or worse. So this is, I'm talking about the acute phase. Let's focus on that for a second. Now, briefly about the management, Dr. Lewis already and Dr. Lewinter mentioned it briefly. The acute phase is usually you have to start with 2 medication and avoid 1 medication. The medication that are considered a standard of care right now, based on the guidelines and multiple research and papers done before, especially by Dr. Imazio and others, is starting with NSAIDs. So NSAID is non-steroidal anti-inflammatory medication, can be ibuprofen, can be aspirin. It depends what your cardiologist and what your country kind of do for your NSAID as a first line. And the second thing is the colchicine. Colchicine is a medication that has been proven before to treat gout, but also historically has been used to treat as well the pericarditis. And there is a recent, kind of indication as well as added to the colchicine, which is prescribed by 1.2 milligrams as a bolus dose, and then 0.6 milligram twice a day. The regimen that is recommended is at least for 30 days, as well as the NSAID has to be given as well for a minimum of 10 days during the acute phase. This is for somebody who just got exposed or just had a pericarditis.
Great, thank you. Dr. Klein, this question is for you. Why are IL-1 treatments, Kineret or Arcalyst, considered as a third-line defense after everything else has failed, and not sooner as a treatment option? Are there downsides to IL-1 treatments, and will my symptoms return after I stop taking the IL-1 treatments?
Okay, thanks, Rachel, and the panel for so far so good, expert panel. So I think if I can generalize for our group here, that I think this is a very, it's a big area. It's a sort of renaissance in pericarditis, because as you heard, now we have an imaging biomarker, specifically advanced imaging to, as Dr. Alres mentioned, to see how intense the pericarditis is, perhaps what the prognosis is. And now, just to answer the question, now we have a new field of biologics, in particular drugs like anakinra or rilonacept. In our trials, we, especially with rilonacept, it's called the Rhapsody trial, we showed that this particular agent was very powerful in treating active pericarditis during a flare, and also prevented recurrences compared to placebo. Very dramatic effect. And as you know, that particular drug was approved by the FDA. And in our patient population was pretty tough patients. These were often prednisone dependent, colchicine resistant patients. So the question is, why do we have to wait so long before we can give this? Well, first of all, it's a very expensive drug. It has to be approved by insurance, but there was some thought among experts like ourselves as perhaps instead of steroids, if you fail the NSAIDs, the colchicine, the exercise restriction, and you don't want to get the side effects of steroids, perhaps we could actually introduce that a little bit earlier. So it has to be tested, and some of the groups are looking at that aspect. So in other words, moving from third line to second line therapy, also especially with the inflammatory if there's a inflammatory phenotype, those biologics will work tremendously versus non-inflammatory phenotype. So I think in time it could probably be studied and perhaps used earlier. Are there downsides? Like all these drugs, like steroids or Imuran, and steroids, you're immunosuppressed. So definitely on biologics, you're immunosuppressed. So you're more prone for upper respiratory tract infections. When you do inject either with anakinra or rilonacept, you can get a localized red reaction, and there's ways to counter that. You can ice that area. Sometimes you can take Benadryl, and there's some other things. You can warm up the syringes to help with any reactions. So obviously, it's better not to be on them, but these are targeted therapies as opposed to NSAIDs, colchicine, and steroids, which are not targeted. So the $1 million question for the panelists and the audience is what happens when you stop? And to answer that question, we don't really know. I can just talk from my own experience that, for example, with anakinra, which is a very short-acting interleukin-1 blocker, that I often treat for a year, close to a year, and then I taper slowly over many months. It's a very short half-life, and there are some people with very severe cases that it takes well more than a year, and has people several years on anakinra, maybe 1 or 2 shots a week. With rilonacept, we don't have the data, but I probably would expect that for the very severe cases, we don't know for sure that 1 year may not be enough, and we'll have to look at some of that data. But that's works in progress for our panelists and for researchers. But I think, as I mentioned, it's a very exciting era for this field.
Thank you. This next question is for Dr. Lewinter. Dr. Lewinter, how long should a person with pericarditis be on triple therapy? And can you define triple therapy, please? And are these medications safe during pregnancy? Mute.
Sorry. Let me define triple therapy first. It's already been done by a couple of speakers, but it means someone who is receiving 3 medications of the 3 major categories of anti-inflammatory drugs that are conventionally used to treat pericarditis. So I'm not talking about the IL-1 inhibitors that are the recent drugs on the scene. So this means an NSAID, which can be aspirin or something like ibuprofen, and colchicine and corticosteroids. If you're on triple therapy, by definition, you've got a bit of a problem because straightforward patients respond very nicely, as been mentioned, to an NSAID and colchicine. So really what triple therapy almost always means is addition of a corticosteroid, typically prednisone, to those other 2 types of drugs. And it's because there's a problem. The patient's not responding well, patient's having multiple recurrences, things like that. So how long a patient remains on any treatment for pericarditis depends on the treatment response. So there's no magic time that patients should be on triple therapy. It all depends on how well you're responding. And generally, we like to see symptoms that have disappeared and a reduction in the inflammatory markers which have been mentioned before, CRP, erythrocyte sedimentation rate. We like to see those go down to normal. That's a sign that your patient is probably ready for attempts to taper these medications. So not only is there no very specific time that should be on triple therapy, it depends on the treatment response, but in general, in treating pericarditis, you do not want to stop drugs abruptly. You want to taper drugs, especially corticosteroids, and over a reasonable amount of time. So I think that answers that question. And you asked about pregnancy, NSAIDs, and that includes both aspirin and drugs like ibuprofen. These are aspirin is called a COX-1 inhibitor. It's cyclooxygenase is an enzyme that results in inflammation, and drugs like ibuprofen inhibit two forms of the COX enzyme. But in any case, those drugs are tricky during pregnancy and can cause some significant problems. And therefore, in general, they are avoided. There are certain circumstances in which you might use one or the other in a short-term basis, but in general, those drugs should be avoided during pregnancy. On the other hand, colchicine is very safe in pregnancy, and corticosteroids are in general quite safe in pregnancy. So in pregnant patients with pericarditis, generally some colchicine or perhaps colchicine plus a corticosteroid like prednisone would be the favored approach to treatment.
Thank you.
Great, thank you. I have a couple of lifestyle questions that came in. Dr. Lewis, I'm going to start with you. Does anxiety have an effect on pericarditis? And does an anti-inflammatory diet help with pericarditis management?
Thanks, Donna. That's a great question. I think I'd like to start by saying, first of all, anxiety is normal in patients with recurrent pericarditis. You live worried that this thing is going to come back. And so it's normal to be nervous, and it's normal to be a little bit anxious related to all of this. Unfortunately, anxiety does have an effect on our pain receptors. And we see this in a lot of other medical conditions that's not pericarditis. And so we know that if we're anxious, it increases our sensitivity to pain. And so, yes, unfortunately, anxiety does have an effect on pericarditis. And the two do go hand in hand quite often. And so we need to alleviate pain. And that sort of helps with getting rid of anxiety somewhat if we get good control of pain, and help reassure and get people a little bit more relaxed in order to relieve their anxiety related to their illness. So I think the two are really hand in hand. In terms of your second question related to anti-inflammatory diets with relationship to pericarditis, unfortunately, we have no strong data. There has not been any clear studies that have looked at anti-inflammatory diets in managing pericarditis. And I think that's a great suggestion, and maybe this group should go forward and look at that. But, my common sense approach would say, as long as your anti-inflammatory diet is something reasonable and you want to try it, I think it's reasonable to try it. It's reasonable to see if trying it helps. If it helps, great. If it doesn't help, then you can go back to what you usually do. But I don't foresee any harm from trying an anti-inflammatory diet.
Thank you. My next questions are for Dr. El-Rayes. How do I find a cardiologist that understands pericarditis? And when would you recommend a pericardectomy? And maybe say what that is.
Yeah, it's two very diverse questions. So how to find, number one, by attending this webinar, and also by going to the Pericarditis Alliance website. definitely there is a lot of resources there, and the team doing phenomenal. Donna and everybody's doing phenomenal team putting resources for the patients, because geographically we are dispersed, and but you definitely want to go to places where they treat and handle these conditions on routine basis. So definitely the Alliance is the first place to start. As Donna mentioned earlier in the webinar, she's going to post the contact information. And if you contact any one of us and we know where you are, we can connect you with the closest cardiologist or rheumatologist who has been treating these conditions. There is also, I want to put a plug for the Facebook group that has been built since 2016. It's a lot of patients who has pericarditis, a lot of discussions happening, and also that we have been putting some resources there for them, and also information about their physicians. Now, moving to the next more clinical question is about the when to consider pericardectomy. I had the privilege to train as well as to work on research with Dr. Klein, and during the 5 years course of working with him, it's very rare that he refer patients, or personally, I didn't never done it, but I'm speaking, maybe Dr. Klein can elaborate. Only 2 times that I witnessed that he referred the patient, young patient who has recurrent pericarditis. So, but in terms of clinical indication, is patient who develop what's called constrictive or effusive constrictive pericarditis, meaning it's very adhesive disease, very thickened pericardium, putting pressure as well as restraining the heart chamber from expanding properly. So it's causing blood pressure to be dropping, as well as a lot of fluid overload, and causing a condition called heart failure because of the constriction. So this is one of the strongest indication that I have seen, as well as we have referred patient for, is the constrictive pericarditis. The other indication is, which is very, very rare and in very selective cases, is the patient choice when they are kind of sick of the recurrent episodes and becoming a lifestyle compromising disease where they have recurrence after recurrence and then always in the hospital. Then stripping of the pericardium, not 100% will guarantee complete resolution of the symptoms, but definitely is one of the last resort options that oftentimes we refer patient for.
Actually, Don, if I can chime in. So Dr. Alvarez was a very good fellow, and obviously he's very accomplished now. So the training on pericarditis was very worthwhile, but very good fellow. But in terms of pericardiectomy, let me just tell you a little anecdote. I was invited to the Mayo Clinic to give a grand rounds, and I gave a nice fancy talk about the biologics and all the newer treatments. And then one of the surgeons stood up at the Mayo Clinic, says, "Why not just do a pericardiectomy?" And it has some reason to do that. And since Dr. Alvarez was being at Cleveland, we do pericardiectomy for the recurrent pericarditis, so for intractable pain, probably 2 a month. So it's becoming a bigger indication for, I wouldn't do it obviously, 1 or 2 years into this, but if you've had this 3, 4, 5 years, definitely a consideration. And when I ask my patients, should we have done it sooner? And they often say yes. It's not 100%, but it is definitely a consideration, and maybe Alan could chime in about that point. Maybe Alan, about pericardiectomy.
No, I completely agree with Dr. Klein that, yes, it is an effective treatment, but we all try very, very hard to push it as far down the list as possible in order to save people from an operation. People frequently say, "I wish I'd done it earlier." I think the most important thing with pericardiectomy is making sure that there's no other cause for chest pain. Because if we take out your pericardium and the pericardium was not the cause for your problems, we're not going to fix your chest pain. The second thing that I would say, particularly in patients with recurrent pericarditis due to inflammation, is that it is exceptionally important regarding who is the surgeon doing your pericardiectomy. Because I've worked in 3 different countries now where I've seen a variety of different pericardiectomies done. And the reality is the operation for constrictive pericarditis is completely different to the operation for recurrent pericarditis. In constrictive pericarditis, they need to take out a small amount of pericardium and it resolves the problem. But in recurrent pericarditis, it's very important that the surgeon takes out as much of the pericardium as is physically possible. And so I would generally urge my patients to consider having it done at an expert center that does a lot of pericardectomies for recurrent pericarditis.
Great answers. Thank you all so much for chiming in on that question. Now move to Rachel for some questions about COVID.
Yes, our questions related to COVID-19. And Dr. Klein, the first question is for you. Why are people getting pericarditis after the COVID-19 vaccine? And do vaccines in general trigger pericarditis flares?
Okay, Rachel, excellent questions. And so a lot has been written about the topic. Now, let me just back up a little bit. Let me start with the COVID-19 infection. So if someone's unfortunate to get the COVID-19 infection, it can cause a mild pericarditis. Initially, the different series perhaps inflated how often this occurred, but it's probably anywhere from 2 to 15% of people could have some myocarditis or pericarditis just from the viral infection. Then the other thing would be the vaccine, especially the mRNA vaccines, the Moderna and the Pfizer can have a myocarditis. It's a little different phenotype. It's much less than the viral infection. And it's the phenotype for especially the myocarditis would be younger men with a lot of testosterone. So basically 19-year-old men that present with this could develop myocarditis. Now the pericarditis, you could have a little bit later, usually older people, not the 19-year-old men, but and it could be a little more delayed. But in general, I want to emphasize that usually the getting the COVID and the possible complications a lot worse than getting the vaccine. Why do you get the vaccine-related myopericarditis? Well, perhaps there's a lot of different theories. One theory would be in the formulation. There's a lipid, lipid nanoparticles associated with the mRNA vaccine. Sometimes you get a reaction to that. Sometimes the vaccine activates your innate immunity, exaggerated immunity. So there's a lot of different theories, but as I said, I want to emphasize that it does exist, but it's much less severe than actually getting COVID myocarditis or pericarditis. But a lot of interest, a lot of review articles on the topic. I should mention that I see 4 types of patients with this field. There are people with COVID infection that they come to Cleveland Clinic, I'm sure other places as well. They have a lot of complaints and you don't really find anything. And there are others that definitely you find on your testing and symptoms that there's definitely a mild pericarditis. Similar with the vaccine, we try to take a very good history to see how close to the vaccine was the symptoms. But I did mention that pericarditis can occur a little bit later than the myocarditis. And we look to see what phenotype, what age of the patient, whether they're male or female. And actually, at this point, maybe I could ask one of my other panelists to comment since it's such a hot topic about this. I see Dr. Mazzio has come on. Massimo, can you maybe comment about the vaccine and mild pericarditis?
Yes, thank you. Thank you very much for this question, very important. So in my experience, COVID infection is associated with an increased risk of pericarditis and myocarditis. Generally, in my experience, also in clinical practice, the pericarditis and myocarditis associated with COVID infection is worse than those associated with the vaccine. The risk of pericarditis and myocarditis associated with the COVID vaccine is relatively low, and so we can see that the patient with COVID has a risk 5 to 10 times higher with COVID infection rather than vaccine. So even nowadays the vaccination is strongly recommended in patients with a previous pericarditis if they are in a stable situation without the disease, so in stable remission. So my experience is that the worst cases can be observed during COVID infection and not after vaccination.
Dr. Amasio, since you were just on here talking, welcome. Thank you for coming. I have another question for you. Does a person have a new type of pericarditis because they got it from COVID or from a COVID-19 vaccine?
Well, in my experience, pericarditis associated with COVID is generally not related directly to the infection, the viral infection, but to the inflammatory response that is caused by COVID. So my approach is similar to pericarditis not associated with COVID, either for the diagnosis and the treatment. So I follow the same treatment algorithm I follow for a patient with pericarditis without COVID. So starting from a non-steroidal anti-inflammatory drug and colchicine as a first option. If not responding, I consider corticosteroids together with colchicine. And in more severe cases, I consider even the use of anakinra or anti-interleukin-1 agents, rilonacept, in those not responding to corticosteroids and colchicine.
Thank you. Dr. Lewinter, this next question is for you. Is the vaccine efficacy blunted by biologics or the IL-1 inhibitor treatment, or immunomodulators, or prednisone? And when would be the best time to receive the vaccine? For example, if you still have inflammation due to pericarditis, is it advisable to go ahead and get your next booster of the COVID-19 vaccine?
Thanks. I get a lot of questions about this, and there's not a lot of data. So I'm constantly disappointing people by not giving them the sort of definitive answers they'd like. Let me just answer the last question first. In general, I think it makes sense to advise patients not to get vaccines or boosters when they have an active pericarditis, for fear that somehow this would interact and cause worsening of the pericarditis. And again, no real data, but it's common sense to say that. And then with respect to biologics, this is another kind of interesting, slightly complicated story. Once again, no data, but the biologics interfere with this IL-1 business that you've heard about, which is a specific component of the immune system. When you give a vaccine, you want to get an immune response. So you might think, well, if I inhibit the immune system, that's going to mess up the vaccine. But in fact, the IL-1 inhibitors inhibit a part of the immune system which has little to do with the vaccine response. So I don't know the answer to that question, but it brings up some interesting problems to consider. Finally, IL-1, which is where this therapy is directed, is thought to play a role in the pathophysiology of COVID. So it may be good. And as a matter of fact, early on, I think that anakinra was actually trialed a little bit in COVID. So it's a messy business with no data. I would not let a patient who's receiving a biologic, who's without symptoms, without evidence of active inflammation, I would not let that get in the way of getting the vaccine. You always have to consider the risk-benefit ratio here. And COVID is still a big problem in terms of getting ill. With respect to some of the others, the CDC recommends that you should not be taking NSAIDs before you get vaccine. That is based, once again, on some animal data, not a lot of animal data, and there's no human data to support that one way or the other. But again, that is the recommendation, and probably makes sense to try and avoid NSAIDs if possible. And there is essentially no data with respect to colchicine and prednisone and how that might interact with the vaccine. Prednisone, again, is a very broad spectrum, if you will, anti-inflammatory drug. And you might think that it would inhibit the vaccine response. But again, there's just really no data to support that one way or the other. My view is that probably none of these things have a major effect on vaccine efficacy, with the potential exception of prednisone. But I have just as little data as anyone else.
All right. Yeah. Thank you. Those are hard questions.
Yeah.
Hard to nail down. Donna, I'm going to send the gavel or whatever to you. You get the talking stick.
Thank you. Thank you. It looks like we're at about 5:53, so I will do my best to get through our last series of questions. And these are questions on the long-term effects of pericarditis. So the first question I have is for Dr. Alvarez. What are the long-term effects of recurrent pericarditis, and can it lead to heart failure or other complications?
Yeah, we mentioned that briefly. I will just go in 1 minute. Definitely, if you have recurrence, means your pericardium getting thickened, means you are at risk for constriction, and eventually, definitely, you are at risk for heart failure. Not because the heart muscle is weak or intoxicated, or because you have a blood supply in compromise getting to the heart muscle. It's purely because instead of your heart sitting in a water bottle, kind of rubbery space, it's becoming in a glass. So it's very stiff and cannot expand and fill the way it should be. So yes, down the line, definitely, if it's untreated, the more recurrence you have, the higher chance you're gonna have this consequences. Second thing is the volume overload status and reading diuretics. And that's, as we mentioned earlier, if you reach that phase, then pericardectomy or stripping of the pericardium is needed.
Thank you. Dr. Klein, we received a lot of questions about exercise or activity and pericarditis. What kinds of activity or exercise is recommended for your pericarditis patients? And we had patients writing in and saying, will I ever be able to exercise like I used to?
Donna, that's another $1 million question, almost like similar to the COVID vaccine. So exercise is probably one of the biggest concerns for patients. Pericarditis often affects people in their prime, and people who like to go to the gym or to do, the Peloton and things like that. In my experience, and I'm sure others, that active exercise, especially when you're inflamed, will aggravate those symptoms. So I have a policy, maybe I'll change. First thing I'll say is that we have to study this, and this is a active area of research. But in general, if you have active recurrent pericarditis or acute pericarditis, I don't think it's a great thing to exercise, but we tell them to sort of try to keep your heart rate down. I give an analogy like walking your dog. If you don't have a dog, you can walk your cat, etc. But try to keep the heart rate down. Dr. Mazio and others have shown maybe beta blockers may be useful to get that heart rate down. Now, question is how long should you really, not try to get your heart rate up? Traditionally, it's said that, if your symptoms go away, your CRP normalizes, you probably can resume your exercise. Perhaps athletes a little bit longer, maybe 3 months. But in my experience, I get a lot of calls when they don't follow my advice that they've had a flare because they've exercised. We are doing a study with a digital watch, the Whoop device. We're going to compare people and monitored by their watch to see. It'll be an active group. Let's say people go to the Peloton and those that are just walking their dog to see who flares first. So it'll be a pilot study, and we want to look at this. But it's active research. Last thing I would say is that we don't know on biologics whether that's a game changer that you can exercise. So we've had professional athletes that we say that the only way you can play is to perhaps you can't be an NSAID, because if it's a contact sport, you can bleed. But if you perhaps go on biologics, but it's still that particular athlete have to retire. But I think that's a fair question. Can you exercise if you're stable on biologics?
And is the answer yes, you can?
Well, the answer is we don't know.
Okay.
Don't know, and I'll be curious.
It's
We don't have
popular
enough time. We don't have enough time for this point. But that's the $1 million question.
Thank you so much. Okay, we have just a couple more minutes left. Dr. Amazio, I'm going to ask you another question. If I've had pericarditis and ongoing flares for years, how likely is it that I will ever heal?
Well, generally, almost all patients will have a resolution of pericarditis. It depends on the individual basis. We have patients that can have a relatively quick resolution of pericarditis following conventional therapies. Other patients have a longer course, probably reflecting a different etiology, and probably the most complicated cases are those with an autoinflammatory mechanism, having several recurrences and requiring long treatment with biological agents. But I want to reassure patients that nowadays we have more individualized treatment that we can offer to patients. We have biological agents that can be very helpful for more complicated cases with corticosteroid dependent and colchicine resistant. So I'm confident that the majority, all the patients at the end will be able to come to a resolution of their pericarditis.
Thank you. We have 1 minute left. I think some of these questions have already been covered. I would just say, I think I have one question here that's asking about resources available for people living with pericarditis. We know, of course, the Pericarditis Alliance is available. Would anyone like to chime in with any other suggestions they have for their patients that are living with pericarditis?
I have just one comment because I see a lot of conversation happening on social media and a lot of people doing search. I just would like to advise them that not everything comes on social media or on Google search is accurate. Make sure this information has references and supported by most recent evidence from some scientists or experts in the field before make any judgment or share this information that might be not true. So make sure you have a good reference to the information shared. But in regard to so far, to my knowledge, is the best source so far is the pericarditis.alliance.com, which is the website.
.org
is the website is that really that you can rely on in getting information and connecting to find answer.
Thank you so much. Well, it's 6 o'clock, so I just want to thank all of our doctors for their wonderful participation this evening, providing answers to really tricky questions and a lot of insight for our patients and family members and supporters. So special thank you to all of our guests. We'll run again your contact information on a slide as we close out the program this evening. We ask that you also please check our website, which is pericarditisalliance.org. You'll have the opportunity to read the biographies of our presenters this evening and also see again, it'll come up here on the screen again, where they're located so that you can reach out to them with any questions that you might have. We've seen some questions come in during the chat that we didn't get to this evening, so we hope to answer them in a future webinar. Thank you for being with us. Thank you for your support and have a great evening. Good night.
Okay, thank you.
Thank you, Donna.
Bye-bye. Bye-bye. Thank you.